it's just, we're talking about comprehensive overview of strategies to break the cycle of chronic disease and promote long-term health from a cardiometabolic renal setting. I have a few questions for Dr. Waleed, but I'll just interchange with Dr. Bassam, and we might not stick to the questions here. Dr. Waleed, why are diabetic patients more prone to coronary artery disease compared to others? And as mentioned from the previous panel, that newly diagnosed type 2 diabetics are 25% risk of having pancreatic cancer. So what's the cardiovascular issue? Well, what's the etiology?
So good afternoon, everyone. I'm glad to be here with you this afternoon. So the diabetes is known as a disease for the sugar, but it's not. It's systemic disease.
Closer.
Yeah. And systemic disease means it affects all the organs in the body. And what is happening in the diabetes is having us a lot of cascades, giving us a cardiovascular damage. So starting from high probability of these patients to develop atherosclerosis in the coronary arteries, starting from chronic inflammation, stiffness of the vasculature, moreover, having a chronic inflammatory state with actually an impaired atherogenicity, which can affect thrombosis and leading to cardiac events like MIs. The other thing is the insulin resistance. This gives us actually more like our factories are working overwhelming to catch up the extra glucose in the body, which gives us more inflammation and more chronic state of inflammation in the blood vessels. Moreover, the vessels become a little bit weaker than expected with the normal population, which leads at the end of easy getting atherosclerotic cardiovascular disease. So moreover, the patients with diabetes are prone to have microvascular complications like the kidney problems, nephropathies, and retinopathies, and also more important, the autonomic neuropathy, which can give us also a chance of getting highly burdens of atherosclerosis, and at the same time, they might not feel the same pain the regular patients feel while they are having cardiac or vascular symptoms. So we might have easily a silent angina or whatever great complications without being noticed. And that's why our renal metabolic clinic aiming to detect these people at an early stage, starting from the micro or macro before they develop actually advanced type 2 diabetes and its complications.
So, how do we assess the risk?
So the risk is assessed all over the body. We start from the blood testing, family history, personal history, and some procedures we do to assess the vascular system. So we start from the family history. If the patient is having a family member having familial hypercholesterolemia along with diabetes, also any history related to sudden cardiac death at younger age of the family members. Actually, also this leads us to another question. If a female patient is having a preeclampsia, this also might be a cause of premature coronary artery disease. And we send for some blood tests, the regular ones. We know all the cholesterol levels, the A1C levels. We send also for lipoprotein little a's and ApoBs, and also the high sensitivity CRP, which gives us a hint on the chronic inflammation ongoing into the body. All of these are integrated with some imaging, like the vascular imaging. We assess the carotids, we assess the peripheral arterial diseases with the ultrasound or with the ABIs, and we tend to go more further to the coronary artery assessment with calcium scoring or even CT coronary angiography if needed according to the patient cascade. All of these come together in a certain pocket to determine the risk of the patient in a 360-degree assessment level.
Thank you. Some people might think, what's kidney got to do with cardiometabolic renal? So, Doctor, please tell us, what are the kidney involved in the cardiometabolic renal clinic, and why it is we can assess, risk stratify, and prevent further long-term complications?
Yeah, thank you very much. Good afternoon, everyone. Thank you for having me. Thank you for the question. It's a great question. So first of all, we need to understand that we have three organ systems that are interconnected to each other. So an impairment in one organ system means also an impairment in the other organ system. So they are interconnected, and they also share the same or similar pathomechanisms. So starting from the insulin resistance, as mentioned by Dr. Waleed, over the oxidative stress processes, the chronic inflammation, the systemic chronic inflammation. So they share the similar pathomechanism. So it absolutely makes sense to have them all under one umbrella, because this will help us to early detect the conditions, but not only that, also to facilitate the early intervention. So that means early detection means early intervention, and having with that a holistic, multidisciplinary approach within the team, and offering the patient a tailored, individualized, but treatment where the patient is in the center. So, and this at the end will also reduce the burden we have on the healthcare system. So there is also a huge benefit in that. So now, when it comes to the role of the nephrologist within the team, within the multidisciplinary team, I think we have a very good experience, an excellent experience in Imperial College with Dr. Farhana and Dr. Waleed, because we have established under the lead of Dr. Farhana the cardiovascular kidney metabolic clinic, and we can see these patients together. So my role as nephrologist is, first of all, of course, to assess and monitor the kidney function, to ensure that, for example, that there is a safe dosing of the medicine we offer to our patients, to look at prevention, how we can prevent the progress of the chronic kidney disease, because we know now that the chronic kidney disease is also a marker for the cardiovascular disease. So with that said, the nephrologist will also take care of the complications that can result from the CKD. So, and these complications can also affect the cardiovascular mortality. So when it comes, for example, just to give an example, for instance, the anemia, this strains the heart also. The mineral bone disease and advanced chronic kidney disease might also cause more calcifications, atherosclerotic changes, worsening with that the cardiovascular mortality. And with the endocrinologist, with the cardiologist together, we can achieve better outcomes. So the role of the nephrologist is not anymore just to slow the progression. This is one side of the coin. The other side is to reduce the cardiovascular risk. This became now in the under the concept of cardiovascular kidney metabolic syndrome. This became now the new goal. So to reduce the cardiovascular risk rather than just preventing the dialysis or reaching the dialysis for the patients. As we know, maybe, as you know, 90% of our patients, of CKD patients, unfortunately, they don't even reach to the end-stage renal disease. They die years before that due to the cardiovascular complications. So,
I have a question for Dr. Bassam. Dr. Bassam, what's sleep got to do with it? Yeah, as a patient, I'm coming in. If I have diabetes, why is sleep is so important?
So I hope everybody can hear me now. So sleep in general is something that it's very important need of a human being. Between 6 to 8 hours is good for concentration, it's good for your longevity, it's good for well-being. But also, we noted that people who does not have, or people who don't get enough sleep because of different reasons, they tend to have more cardiovascular events. And specifically, when it comes to obese people who get obstructive sleep apnea. So snoring is bad and it's annoying and we don't like it. But what we're really concerned about, if you have apnea or not, if you stop or pause breathing while you're snoring. Because when you do this and then you stop and it happens at night, your heart rate goes up, your blood pressure goes up, the brainwave changes, and the oxygen goes very low, the CO2 goes up, and that's why you wake up. You don't wake up because of all these things, you wake up because the brain is very sensitive if your CO2 goes up. And a good example of this, if you swim and if you dive, usually the first thing when you come out of the water is, do you breathe in or you breathe out? You breathe out. Everybody thinks that you open your mouth to get more air. No. You open your mouth because the brain does not want those extra CO2. So you do this.
That's true.
So, and this is what happens at night. If the CO2 goes up, then the brain says, please wake up. And then you break up, you breathe that CO2. So these things happen in an hourly basis or a minute basis. The more these things happen, then you have a sleep apnea, and then we put this as a risk for cardiovascular diseases.
So sleep is really important. When should we sleep? What time?
So
I know it's not in the cards, so I'm just free,
Okay, well, so do as I talk, don't do as I do, because I don't sleep early. So let's say, classically, ideally, you should sleep after 11, not after 11, so 11 or more. So this is the general consensus. If you can make it, then between 1 and 5, you should have a solid 4 hours sleep. Because this is good for your brain to do the restart, put the extra files here and bring the other file here and put all the information you need to do. And if you have a problem that it keeps you thinking, talk about it, write it before you sleep, so that your brain is empty in your cycling pen, so when you sleep you don't have to think about all those things.
I believe that we should, in every clinic, even GP, we should really screen for sleep apnea. To be honest,
we published this actually.
Yes.
We think that 8% of the population have a problem with the sleep, out of which probably 3 to 4% of the population, they have a sleep apnea. Then if you take the population of an obese people, I would say 1/3 to 30% of them or more, they will have a sleep apnea.
And so going back to the CKM clinic and looking at sleep apnea and screening for it, what's the importance of treating sleep apnea and how do we treat it?
So let's say that we diagnose somebody with a sleep apnea. The first thing we will tell him or her to lose weight. Because if you lose between 7 to 10 kgs, you have 80% chance of totally being treated, cured from the sleep apnea. But because this doesn't happen, it doesn't happen quickly, even with Manjaros and even with all these things, it doesn't happen that quickly, all right? So we say that we should put people on a CPAP. So you think about it, just simple mechanics. You have your airways is a tube that is closed. We need to push air to keep it up. So we give them CPAP, which goes into the face, nose, or mouth, and it pushes pressure air, does not push oxygen to keep that pipe out. So once we do this, we've noticed that their blood pressure gets better. And there might be, in some cases that it's hypertension related to sleep apnea only, they don't have to take medication occasionally. And then all the other metabolic parameters, it gets better. Even we published paper with 2 of my PhD students about the effect on asthma, on gastroesophageal reflux, and all these things. So you get a lot hit by only one stone.
That's amazing. So sleep is really important. Sleep before 11. But I have a question to both Dr. Bahaa and Dr. Waleed. We talked about sleep. Can we look at sleep and HFpEF? So can you explain what HFpEF is when what we screen for in the clinic? So this is prevention. First, early detection so you can prevent complications. Go ahead.
So heart failure actually has some subtypes, but the main concept of the heart failure is that the heart cannot withstand the body needs, even if it's not giving enough blood in the systole, or it does not give the enough blood in the diastole. So we have two phases of this. One with heart is weak, it's a little bit weaker than normal, low ejection fraction, or we have a patient with preserved, a powerful heart, but the relaxation is poor. So to the later part, the heart failure preserved EF actually contribute majorly to the metabolic syndromes, OSAs, and this comes from a lot of aspects: obesity, hypertension untreated, and CKD as well. So if we take all of these together, we will find the picture of a patient who is obese, having short of breath with minimal exertion, also having OSA during the night. And if he has all of these together, we are more prone to have arrhythmias. As Dr. Bassam has elegantly said, the brain is very sensitive to high CO2 level. The heart as well is very sensitive to low oxygen levels, hypoxia, which gives us arrhythmias, especially the left atrium. This is a precursor of any arrhythmias in the body. So arrhythmias means abnormal heartbeats, which is also some might be a critical situation. So along with the pump failure of the heart in the systole or diastole, along with the arrhythmias, along with the peripheral vascular disease, oxidative stress from the metabolic syndromes, and more importantly, the sympathetic overactivity. The body is trying to get things out, so it's working at a higher gear. And this makes it a little bit more risky, because this makes your cortisol levels are high, water and salt retention, increase your hypertension, gets everything at the edge. And at this time, we have to deal with all of these parts separately. We have to treat OSA, we have to treat obesity, we have to treat diabetes, we have to treat CKD, we have to treat dyslipidemia, and for sure we have to treat the heart failure or arrhythmia complications as well.
Dr. Bahaa, what do we do with people who have sleep apnea and have diabetes?
So refer
Is
them
there
to
a
the
kidney?
pulmonologist.
And what's the kidney effect?
So the
What's
kidney,
yeah.
the kidney is in an indirect way affected also. So when it comes to heart failure, sleep apnea causes heart failure, as mentioned by Dr. Waleed. We know that heart failure as a primary cause, so we have the cardiorenal syndrome. So we have a cardiorenal syndrome, it's bidirectional. So the kidney can affect the heart, but the heart, when it has a primary disease, can also affect the kidney function at the end. So we have 1/3 to 2/3 of patients, according to many statistics and meta-analysis, 30 to 60%, almost 1/3 to 2/3 of the heart failure patients with other cause than metabolic disease, congenital for example, they develop CKD, depending on severity of the heart failure and kind of the heart failure. So it's all together connected. So, and one organ can affect the other organ. So if you go today, for example, to the homepage, to the website of the WHO, it was shocking for me, like some months ago, to come to the conclusion that CKD became now the 7th leading cause of mortality worldwide. This makes it very clear why we need preventive measures, why we need people looking at those patients who are really at high risk. And with that, we can, as said before, reduce the global burden and improve the quality of life of those patients with the preventive measures we have and with the medications, the new agents we got in this era.
Thank you. There's like a new kid on the block, or it's not really new. So SGLT2 inhibitors are being prescribed by everyone, cardiologists, endocrinologists, and nephrologists, and it's like you're the like Excalibur, and you're like, let's all prescribe it. So what's the importance of SGLT2? Not that I'm promoting it, but I'm just saying that and also GIP and GLP-1 agonists are very helpful. So if you can
Yeah, Dr. Farhana, actually, we are very lucky to live in this era. So if we would have asked ourselves this question like 1 decade before, we would would have had only one answer. So we can offer not much to the patients apart from the RAS blockers, the renin angiotensin aldosterone receptor antagonists. We were not able to provide the patients with more drugs or medicine. So we focused, of course, as we are focusing now on the control of the blood pressure, the control of the diabetes as the leading conditions to the CKD and cardiovascular problems. So, but now we are in the era, we have the SGLT2 inhibitors, so they have a class effect. So if you take any of the SGLT2 inhibitors, you will find through the studies, the trials, that they slow the progression of CKD by almost 40%. They reduce the heart failure by 30-35%. If you take the GLP-1s or the GLP receptor agonists, so we have new published the FLOW trial focused on the kidney primary endpoints and promising results also with that. So we are now in an era where we can comprehensively address the CKM syndrome, but of course not to forget the finerenone, the non-steroid mineralocorticoid antagonists. They have lesser side effects than the spironolactone. So we are in an era where we can offer our patients a lot of medicine, and this makes more sense to have all under one umbrella. And we are still open for more development and research on that. And I am confident the next few years we will have more to offer our patients.
So I just want a take-home message from each of our panel members, because we have also healthcare professionals, but I'm sure there are some in the audience who are not healthcare professionals. Any take-home message from prevention to longevity, Dr. Bassam?
So I think we are moving from being a professionals who look after illness to somebody who is advocating for wellness. I think our job in the next decade or so is to prevent people from coming to us. I know this might not sound lucrative or financially appealing, but this is the right way. So if I have a genetic makeup of diabetes or cancer and whatever it is, probably I should start by knowing what am I prone to and try to do a lifestyle that if it's not going to stop it, it's just going to delay it as long as I can. And more than 60% of that can happen by a good lifestyle, from sleep, from exercise, and diet. So do this early, know what you're prone to, and this is the way that we are moving forward.
Thank you, Dr. Bahaa. We're finished, but I'll just your points, and if there are any questions, we'll take them later.
Early detection is the most important thing we have to look at. This is very important. We need to screen our patients. We got some tools where we can screen our patients. So early detection is quite important to prevent and to improve the outcomes.
Dr. Waleed?
I'll just echo my colleagues. So, but a very important notice, smoking, especially the vapes, actually this kills. It's not equal to a healthy population. So please stop smoking, lose weight, regular exercise, DASH diet, Mediterranean diet, and early screening, because some people are more prone to have certain problems than others, as addressed by Dr. Bassam. So early screening makes things easier for the physician, and also you don't get the complications early. This is my message. Thank you.
Dr. Farhana, sorry, can I add just my 4S? I call them the 4S: sugar, salt, smoking, and style, which is lifestyle. So if we keep all of that in mind, I developed the 4S rule for myself to tell my patients about it. And I think if you tell this to other people, share it with other people, the 4S: salt, sugar, smoking, and lifestyle.
As for surprise, don't forget it.
I think we should, as Dr. Bassam said, that we need to move away from illness to wellness, and this is where the key is in prevention and longevity. Thank you very much. If you have any questions, we'll take them on later. Thank you.